Good morning, and welcome to the Assembly Committee on Ways and Means, Senate Committee on Finance, Subcommittee on Human Services. Committee Secretary, will you please call the roll?
Senators Canizaro, Dondero Loop, Stone, Titus, Wynn, Assembly Members Brown May, Dickman, Hafen, Hibbets, Howdigi, Mosca, Yeager, and Chair Monroe Moreno.
Thank you, and I am here. Our chair is feeling a little under the weather. It has no voice, so I'll fill in for her today. We have a work session, members. It's the Department of Health and Human Services Aging and Disability Services Division, the Early Intervention Services. That's the only thing on our work session agenda. We will have public comment at the end of today's meeting. If you'd like to call in for public comment, the number is 888-475-4499. The meeting ID is 859-171-96596, and then please press pound. I'll remind guests joining us in the audience and members to mute or turn off your electronic devices so that they do not interrupt the work session. And with that, I will turn over to our staff to start our work session.
Thank you, Madam Chair. Good morning, members of the committee. I'm Kimber Ellsworth, Senior Program Analyst with LCB Fiscal Analysis Division. In today's work session, we will be discussing one issue relating to the Aging and Disability Services Division Early Intervention Services budget account. There is no action to be taken today. Rather, this work session provides an opportunity for the subcommittees to discuss the issue and provide fiscal staff guidance on how they would like to see the budget brought forth for consideration during the subcommittee budget closing on April 30th. As I noted, this issue relates to the Aging and Disability Services Division Early Intervention Services budget account. Specifically, this is regarding the community provider payment model change, decision unit E266 in the Early Intervention Services budget account 3208. To summarize the issue, through decision unit E266, the governor recommends changing the payment model for early intervention services community providers by replacing the current cost per eligible capitated rate of payment with a fee-for-service model that would provide temporary transitional add-on payments from the program as the payer of last resort, resulting in general fund savings of $10.9 million in each year of the 2025 to 27 biennium, based on updated agency caseload projections provided in March 2025. The subcommittees will recall that the Early Intervention Services Program payment model for community providers was discussed at the January 27, 2025 Legislative Commission's Budget Subcommittee meeting and at the February 25, 2025 Human Services Joint Subcommittee budget hearing of the Early Intervention Services budget account. The governor's recommendation would address compliance concerns identified by the agency and maximize financial resources. However, the subcommittee identified concerns with meeting maintenance of effort requirements, as well as whether the proposal would be a sustainable model for community providers. At the request of fiscal staff, following the budget hearing, the agency provided alternative scenarios that appear to be viable for consideration by the subcommittee that would alleviate some of the concerns identified during these discussions and still change the payment model for early intervention services community providers to fee-for-service. As background, the Early Intervention Services Program works to identify infants and toddlers who have or are at risk for developmental delays. The program provides services and support for families with children under the age of 3 who have developmental delays. Specialized therapies, case management, are provided by community providers as well as the state clinic staff and contracted therapists. Funding for the program is provided primarily through general fund appropriations, as well as Federal Individuals with Disabilities Education or Act, IDEA, Part C grant funds, and reimbursements from Medicaid and private medical insurance. The federal IDEA Part C grant has a maintenance of effort requirement, so all general fund appropriations added to the Early Intervention Services budget account and expended in the upcoming biennium must be continued in successive fiscal years for the state to remain in compliance. State funds budgeted for early intervention services expended in other budget accounts are also part of the maintenance of effort consideration. Historically, the Early Intervention Services program operated under a model in which state staff conducted all case management, service coordination, and oversight activities, as well as the majority of direct services. Prior to the 2011 to 13 biennium, the program began to contract out some services to community providers. In 2013, the 77th Legislature approved the program to split the caseload 50% community providers and 50% state, with the state retaining responsibility for providing screenings and direct services to medically fragile children and children in rural areas of the state due to a lack of community providers in those regions. For the 2023 to 25 biennium, the 82nd Legislature approved the governor's recommendation to eliminate the 50-50 caseload split between the state and community providers to provide families more flexibility in selecting service providers to the extent that funding is available, as well as an increase in the rate paid to community providers from $565 per child per month to $794.88, effective July 1st, 2024. The new rate reflects the total revenue per child served, regardless of payer. This was a change from prior practice, wherein providers previously received a monthly per child payment from the program and retained payments received from private insurance or Medicaid. Although this payment mechanism was laid out in the existing provider service agreement, the agency indicated it had not previously been implemented due to lack of data. The agency indicates that currently all community providers are enrolled with Nevada Medicaid and with most private insurers. The program service agreement requires community providers to bill all Medicaid-enrolled children and to take reasonable measures to seek payment from third-party sources, including commercial insurance, to offset that state payment with reimbursements from private insurers and Medicaid. During the 2023 to 24 interim, the agency implemented a new case management and billing system funded with federal IDEA Part C grant funds, which enables the program to monitor billing activity and track providers' insurance claims, denials, and other billing data. The agency indicates the new comprehensive data system can filter for unsubmitted, denied, or unpaid claims that may be used for reports for follow-up. Additionally, the agency is currently working with its vendor to add a system function to separate clients with no insurance and clients that do not provide consent to bill their insurance, so the program can track and identify whether a child is uninsured or the family did not consent to having those services billed for their insurance. With regard to the family's consent to bill, federal regulations require the program to obtain consent from families in order to bill their insurance for early intervention services. According to a study that evaluated Nevada's early intervention services system, which was completed in June 2024, state policies related to families' consent to bill their insurance vary widely. For example, in Georgia, families that decline consent are responsible for 100% of the cost of their services. In Nevada, the agency and community providers seek consent to bill insurance from the families they serve. However, families may decline consent without any impacts to the services received. For children and families with active individualized family service plans, as of July 2023, for state-facilitated services, more than 97% provided insurance information, and of these, 91.1% provided consent to bill their public or private insurance. However, rates of insurance disclosures to community providers were notably lower, with 92.4% of community providers' clients with individualized family service plans reporting insurance, and only 88.5% consenting to bill their public or private insurance. Federal regulations require the consent to bill. However, That requirement does not apply if a state enacts certain statutory requirements regarding the use of families' private insurance coverage to pay for early intervention services, including no-cost protections for families. If a state enacts such legislation, the state may reestablish a new baseline of state and local expenditures for the maintenance of effort considerations. On page 3 of your document addresses the current payment model that's in place. As noted previously, the Early Intervention Services Program currently pays community providers a monthly capitated rate per child receiving services. Based on a rate study that was completed in June 2022, which informed the rate change approved by the 82nd Legislature, the rate of $794.88 reflects the total revenue needed to cover the cost per child served regardless of payer, on the assumption that actual services delivered may cost more or less than the capitated rate. That is, currently, community providers collect up to $794.88 per child per month, inclusive of reimbursements from all payers, assuming some children will require less expensive services and some will require more expensive services. Under the current payment model, reimbursements received by community providers from other funding sources are not being maximized to offset the capitated payment provided from the state. Further, the agency indicated that during internal budget discussions, it was identified that the current payment process is not compliant with the Federal Office of Special Education Programs Payer of Last Resort or Medicaid payment in full billing rules. The agency indicates several factors contribute to these issues, including inconsistency among community providers in billing other funding sources to their maximum capacity, high number of families declining consent for community providers to bill their insurance for services, and low rate of follow-up on denied claims with Medicaid or managed care organizations among providers for potential reimbursement. With regard to reimbursements, the current capitated payment model does not permit the state to seek reimbursements from Medicaid or private insurance for community provider payments, because the entity that provides the service must be the one to bill for that service. And the process does not incentivize community providers to seek reimbursement to offset the state payment. Further, the current process does not incentivize families to provide consent for community providers to bill their insurance for services. Although the program currently requires providers to bill Medicaid and private insurance for eligible services when granted consent from families, and providers are billing a portion of what could be recouped, the agency indicates the revenue collected by community providers through Medicaid and commercial insurers has not been maximized. In FY 2023, for example, the agency estimates combined revenue from Medicaid and private insurance comprised between 3% and 12.2% of total revenue collected by community providers. The agency indicates that during budget discussions regarding how to increase Medicaid revenue for community providers, it was identified that the current capitated payment process does not comply with Federal Centers for Medicare and Medicaid Services rules requiring Medicaid payments to be accepted as payment in full. Federal regulations require that a state plan must provide payment in full, must provide that the Medicaid agency must limit participation in the Medicaid program to providers who accept as payment in full the amounts paid by the agency plus any deductible coinsurance or copay required by the plan to be paid by the individual. The agency is prohibited from making any additional payments for covered services when Medicaid has been billed. With regard to the payer as of last resort, under the current model, the monthly per child payment of $794.88, which providers receive for each active case, should be reduced by any reimbursements from Medicaid or private insurance, which ensures state and federal IDEA Part C funds serve as the payer of last resort. The agency explained that the current payment process does not hold providers accountable for timely and accurate billing for reimbursement from other funding sources or to follow up on claim denials prior to receiving payment from the state. Thus, the state payment is often made prior to providers receiving any reimbursement for services that would otherwise have been paid from other sources. The table on page 4 is based on the information provided by the agency. and it summarizes the suggested advantages and disadvantages of the current and recommended payment model. The governor's recommendation also begins on page 4. To ensure compliance with federal billing rules and maximize revenues, the governor recommends a change from practice wherein community providers would bill, receive, and retain payments from private insurance or Medicaid for each service provided. The recommendation would change the current capitated payment model of $794.88 per child per month to a fee-for-service model that requires providers bill other funding sources for reimbursement prior to receiving payment from the state. The recommendation includes a temporary add-on payment of $199 for each insured eligible child to cover non-billable program support services and administrative costs, as well as a payment in the amount of $794.88 per month for each uninsured eligible child. The governor's recommendation aims to ensure the system uses all available funding sources before utilizing state general funds or federal funds as the payer of last resort. Further, an additional temporary add-on payment is recommended in the executive budget from the Department of Health and Human Services Fund for a Resilient Nevada budget account, which was closed by the subcommittee on April 8th, 2025. This additional add-on payment would be in the amount of $88.94 in fiscal year 2026 and $100.72 in fiscal year 2027 per child per month, funded with opioid settlement funds totaling $4.7 million over the 2025 to 27 biennium, based on updated agency caseload projections provided in March 2025. In addition to insurance payments received, this would provide the community providers add-on payments totaling $287.94 in fiscal year 2026 and $319.72 in fiscal year 2027 for the insured population, when combined with the $199 add-on payment in the governor's recommendation that I noted for the early intervention services budget account. The agency indicates the amount was determined based on cost analysis in the 2022 rate study for activities that are not billable or covered by Medicaid or private insurance. In the governor's recommendation in the Fund for Resilient Nevada budget account, that add-on payment is noted to be temporary transitional during the biennium, according to the governor's recommendation, and that would support community providers in non-covered, non-billable activities that are required by IDEA Part C. However, it appears the provider non-covered, non-billable costs would be ongoing beyond the biennium. Also, given the maintenance of effort requirement, it is unclear if the add-on payment could be reduced in the future without impacting funding level compliance. To support the transition to community providers billing other funding sources for reimbursement prior to receiving payment from the state, the agency indicates the provider's scope of work would be amended to provide clear guidance on billing requirements, ensuring consistent and comprehensive billing practices across all providers. Additionally, to implement the new model, existing agreements with providers would need to be modified to reflect process changes. The agency has indicated that it would work collaboratively with providers and stakeholders throughout any transition process. While the governor's recommendation would incentivize community providers to bill Medicaid and private insurers for reimbursements, it would not add incentive for families to provide consent to enable providers to bill their insurance, particularly if the family is considered underinsured and has a high deductible insurance coverage limitations, or other cost barriers. Additionally, the recommendation would reduce budgeted state funds, which may impact the state's ability to meet the federal maintenance of effort requirement for early intervention services. The projected savings in the governor's recommendation would result from all community providers billing and receiving payments from private insurance and Medicaid fee-for-service and MCO eligible children. The agency indicates that all community providers are credentialed to provide services and enrolled with Nevada Medicaid and with most private insurers for billing. As noted previously, the program receives funding from the federal IDEA Part C grant, which has a maintenance of effort requirement for early intervention services. To demonstrate compliance, a state must budget at least the same amount of state and local public funds for early intervention services as it expended in the most recent preceding fiscal year for which the information is available. Generally, this means that all general fund appropriations budgeted and expended for the program must be continued in successive fiscal years for the state to remain in compliance. In response to questions following the Legislative Commission's Budget Subcommittee hearing on January 27, 2025, the agency indicated that the IDEA Part C office and ADSD leadership had met with the Federal Office of Special Education Programs to discuss the state's ability to meet the maintenance of effort requirement with the governor's recommendation. The agency indicated that guidance was received on the state's maintenance of effort calculation, which includes funds that were not previously counted, such as the state's share of Medicaid reimbursements and state funds expended for quality assurance and program staff. However, the total amount of state and local public funds budgeted to support expenditures specific to early intervention services and other budget accounts, such as Nevada Medicaid, is unclear. If approved as recommended in the executive budget, the state funds allocated directly to program services would be lower than in prior years. Utilizing the amount of general fund appropriations that supported expenditures from early intervention services from that budget account 3208 for direct services and staff in fiscal year 2024, which is the most recent preceding fiscal year, fiscal staff estimates a baseline of $39.4 million for the maintenance of effort requirement. According to fiscal staff's calculations, excluding state funds recommended in other budget accounts, general fund appropriations of $6.9 million over the 2025 to 27 biennium would need to be added to the governor's recommendation in the early intervention services budget account to meet the maintenance of effort baseline. On page 6, we begin with the options for consideration by the subcommittee. The agency provided multiple alternative scenarios that aim to encourage community providers to utilize all available funding sources, including 3 scenarios that appear to alleviate some of the concerns identified during previous budget discussions. For the subcommittee's consideration, a total of 5 options are summarized, including the primary differences, projected fiscal impact over the 2025 to 27 biennium, and potential advantages or disadvantage of each. Except for the last 2 options, all scenarios would transition the current capitated payment model for community providers to a fee-for-service model and maintain the monthly per-child rate of $794.88 as a safety net for the uninsured caseload. For comparison purposes, all costs are presented based on the most recent caseload projections provided by the agency, which were updated in March 2025. The projections also estimate 18.2% and 35.5% of the children in the caseload are uninsured and underinsured, respectively. Option A is the governor's recommendation in Budget Account 3208, Decision Unit E266. This option would change the current capitated payment model to fee-for-service effective July 1st, 2025 for the insured caseload, including all children with Medicaid or private insurance, and provide a monthly add-on payment of $199 per insured child to cover non-billable program support services and administrative costs to aid providers with the transition during the 2025 to 27 biennium. Service costs for children served by community providers are estimated to total $6.9 million in each year of the 2025 to 27 biennium, funded with general fund appropriations. This option would help ensure compliance with federal billing rules and incentivize providers to maximize collection of reimbursements from other payers. However, it would not add incentive for families to consent to bill their insurance. Additionally, this option would provide general fund savings of $10.9 million per year compared to the current model, and total program funding would fall below the FY24 actual expenditures supported with state funds. Therefore, compliance with the federal maintenance of effort requirement is uncertain. Option B is a phase-down approach. This option would phase down the community provider capitated payments, transitioning the model over time to fee-for-service for the insured caseload, including all children with Medicaid or private insurance. For the first 6 months of the 2025 to 27 biennium, providers would receive 100% of the current monthly rate of $794.88 per insured child, following 6 months at 75% or $596, 6 months at 50% or $397, and the last 6 months at 25% or $199. Service costs are estimated to total $16 million in FY 2026 and $8.7 million in FY 2027, funded with general fund appropriations. This option would eliminate the current capitated payment by the end of the biennium to ensure compliance with federal billing rules and incentivize providers to maximize collection of reimbursements. However, it would not add incentive for families to consent to bill their insurance. Additionally, this option would increase costs by $11 million over the 2025 to 27 biennium compared to the governor's recommendation. Compared to the current model, this option would save general funds of $10.9 million over the 2025 to 27 biennium. Total program funding in fiscal year 2027 would fall below the fiscal year 2024 actual expenditures supported with state funds. Therefore, compliance with federal maintenance of effort requirement is uncertain with this option. Option C would provide insurance assistance at 100% of the capitated rate. This option would change the payment model to fee-for-service effective July 1st, 2025, and allocate up to 100% of the current per-child rate of $794.88 to provide insurance assistance to underinsured children with high-deductible health insurance plans, coverage limitations, or catastrophic medical plans. The allocation would fund families' insurance deductibles and cost shares to encourage families to provide consent for providers to bill their insurance for covered services. The remaining insured caseload For the remaining insured caseload, this scenario would provide a monthly per child add-on payment of $199 to cover the non-billable program support services and administrative costs. Service costs are estimated to total $11.7 million in each year of the 2025 to 27 biennium, funded with general fund appropriations. This option would help ensure compliance with federal billing rules and incentivize providers to maximize collection of reimbursements from other payers. Additionally, although it would increase costs by $4.8 million per year compared to the governor's recommendation, compared to the current model, this option would save general funds of $6.2 million in each year of the 2025 to 27 biennium. Total state funding would exceed the fiscal year 2024 actual expenditures supported with state funds, ensuring compliance with the federal maintenance of effort requirement in the upcoming biennium. Option D is another insurance assistance option. This is at 50% of the rate. This option would provide for the same change as option C, except that it would allocate up to 50% of the per child rate, and that would be $397.44 for insurance assistance. It would provide the same suggested benefits, except the increased cost compared to the governor's recommendation is $1.6 million per year. And compared to the current model, this option would save general funds of $9.4 million in each year of the 2025 to 27 biennium. Total state funding would fall below fiscal year 2024 actual expenditures supported with state funds. Therefore, compliance with the maintenance of effort requirement in the upcoming biennium is uncertain. Service costs are estimated to total $8.5 million in each year of the 2025 to 27 biennium, funded with general fund appropriations. For option E, this is the current payment model. The subcommittee could recommend to not approve the governor's recommendation and instead maintain the current payment model, which provides a monthly per child capitated payment of $794.88 for all children on the community provider's caseload. Service costs for children served by community providers are estimated to total $17.9 million in each year of the 2025 to 27 biennium, funded with general fund appropriations. The cost compared to the governor's recommendation would increase by $10.9 million per year in the 2025 to 27 biennium. The total state funding would exceed the fiscal year 2024 actual expenditures supported with state funds, ensuring compliance with the federal maintenance of effort requirement. However, this option would not address the current compliance concerns with federal billing rules. Further, it would not add incentives for providers to maximize collection of reimbursements from other payers, or for families to consent to have providers bill their insurance for reimbursement. And lastly, option F is the additional add-on payment. Additionally, as noted previously, an additional add-on payment is recommended in the executive budget from the Department of Health and Human Services Fund for a Resilient Nevada budget account. And this is budget account 3060, decision unit E225. The add-on payment would be in the amount of $88.94 in fiscal year 2026 and $120.72 in fiscal year 2027 per child per month for the community provider's caseload. The add-on payment would be a temporary transitional payment during the 2025 to 27 biennium, according to the governor's recommendation, to help fund activities that are required by IDEA Part C, but which are not billable or covered by Medicaid or private insurance. Payments to community providers are estimated to total $2 million in FY 2026 and $2.7 million in FY 2027, based on March 2025 caseload projections, which would be in addition to the funding recommended for any other options funded with opioid settlement funds from the Fund for a Resilient Nevada. During the April 8, 2025 closing of the Fund for Resilient Nevada budget account, the subcommittee deferred this decision and recommended that decisions regarding early intervention services be made during the closing of the Early Intervention Services budget account, which is scheduled to be closed on April 30th, 2025. On page 8, the table summarizes the estimated provider payments for children served by community providers for each scenario compared to the total provider payments for the current model, which is option E, and for the model recommended by the governor, which is option A. When the subcommittee makes a recommendation to close the Early Intervention Services budget account, it may wish to approve or adjust the governor's recommendation, approve or make adjustments to any of the three alternative proposals offered by the agency, approve some alternative payment model, or choose not to change the payment model that is currently in place. Depending on the subcommittee's discussions about any potential changes to the payment model, fiscal staff will return at budget closing with updated projections for the community provider expenditures. Further, with any option that would change the current payment model or not, the subcommittee may wish to recommend a letter of intent be issued to instruct the agency to report back to the Interim Finance Committee on the status of the program or the implementation of a new model and the impact of any changes approved, such as the addition of insurance assistance, as well as any adjustments or statutory changes that may improve the program further for consideration by the next legislature. Beginning on page 9, I will walk through the decisions to be made at closing. And the decision is whether to recommend approval of any of the following options. Option A, the governor's recommendation to replace the current capitated rate paid to community providers with the fee-for-service payment model effective July 1st, 2025, specifically providing for a monthly payment of $794.88 per uninsured child and an add-on payment of $199 per insured child per month. This option would fund provider payments of $6.9 million in each year of the 2025 to 27 biennium and result in general fund reductions of $21.9 million over the 2025 to 27 biennium, updated based on March 2025 caseload projections compared to the current model. Or option B, phase down the payment to community providers, transitioning over time to fee-for-service for the insured caseload, and providing for a monthly payment of $794.88 per uninsured child For the first 6 months of the 2025 to 27 biennium, providers would receive 100% of the current monthly rate of $794.88 per insured child. Following 6 months at 75% or $596, 6 months at 50% or $397, and the last 6 months at 25% or $199 per insured child. This option would fund provider payments of $16 million in fiscal year 2026 and $8.7 million in fiscal year 2027, and result in general fund reductions of $10.9 million over the 2025 to 27 biennium based on March 2025 caseload projections compared to the current model. Compared to the governor's recommendation, option A, this option would add general fund appropriations of $11 million over the 2025 to 27 biennium. Or option C, replace the current capitated rate paid to community providers with a fee-for-service payment model effective July 1st, 2025, specifically allocating up to 100% of the current monthly rate of $794.88 per underinsured child to provide insurance assistance, providing $794.88 per uninsured child per month, and providing an add-on payment of $199 per month for the remaining insured caseload. This option would fund provider payments of $11.7 million in each year of the 2025 to 27 biennium and result in general fund reductions of $12.4 million over the 2025 to 27 biennium based on March 2025 caseload projections compared to the current model. Compared to the governor's recommendation in option A, this option would add general fund appropriations of $9.5 million over the 2025 to 27 biennium. Or option D, replace the current capitated rate to community providers with a fee-for-service payment model effective July 1st, 2025, specifically allocating up to 50% of the current model rate, which would be $397.44 per underinsured child, to provide insurance assistance, providing $794.88 per uninsured child per month, and providing an add-on payment of $199 per month for the remaining insured caseload. This option would fund provider payments of $8.5 million in each year of the 2025 to 27 biennium and result in general fund reductions of $18.7 million over the 2025 to 27 biennium based on March 2025 caseload projections compared to the current model. Compared to the governor's recommendation in option A, this option would add general fund appropriations of $3.2 million over the 2025 to 27 biennium. Or option E, retain the current capitated rate payment model, which provides a monthly per child payment of $794.88 for all children on the community provider's caseload. This option would fund provider payments of $17.9 million in each year of the 2025 to 27 biennium and would require additional general fund appropriations of $21.9 million over the 2025 to 27 biennium compared to the governor's recommendation based on March 2025 caseload projections. And option F, provide an additional monthly per child add-on payment for all children on the community provider's caseload as recommended by the governor in the amount of $88.94 in fiscal year 2026 and $120.72 in fiscal year 2027. This option would fund provider payments of $2 million in fiscal year 2026 and $2.7 million in fiscal year 2027 with opioid settlement funds, which would be in addition to the funding recommended for any other options. And with that, I will pause for questions.
Thank you so much. I know that was a lot, and I'm sure we have a few questions. I'm going to start with Assemblymember Hafen.
Thank you, Chair. And I have more of a statement than a question. Didn't realize you were going to have me go first, or I would have had my notes open. Sorry. I'd just like to say that this is an amazing program, and that it's been extremely beneficial to a number of individuals, and I just had a little text message back and forth, and I just kind of want to read that the program was so beneficial for us. It was truly so amazing, and I'm so grateful for it. And to me, a small investment in this program up front is setting up these children for long-term success. Having said that, I do think that the state policies need to be updated to address the June 2024 study, as well as bringing us within the compliance of the federal regulations, and which, in looking at the various options here, to me, option C is probably the best way of providing additional funds. And again, I'm going to say this with hope that the May Economic Forum comes in better than what we're projecting, and that funds are available, because I do think that we need to fund this program, but I do also think that we need to bring our policies into within the federal regulations, as well as address some of the issues and concerns in the June of the 2024 study. So thank you, Chair.
Thank you for those comments. Assemblymember Brown May.
Thank you, Chair, for the opportunity. A lot of information has been presented. I'm wondering, can we ask questions? The division's here.
I think we can do whatever we need to do to get to the best decision for this legislative body.
If you don't mind, I would love to ask about how we're currently paying the provider network and sustainability in this transition. And I'm curious to know if somebody can talk about the number of kids we're serving currently in this program.
If there's someone in the room that can come up to the table to answer those questions for the committee, we'd be most appreciative.
Thank you. So specifically, we're looking at a potential change in the billing model from a capitated payment rate, which would be managed care, to fee-for-service. And I'm curious to know, first, can you tell us how many kids are currently served or anticipated to be served by this budget?
Good morning, Ricky Robb for the record, Deputy Administrator for Aging and Disability Services. Currently, there's about 3,800 as a full caseload for both state and community providers. We're a little over 45% 45 with the community providers, 55 with state, due to some challenges within compliance. So that's why that number's slightly off at this point. So our current model is that we pay the $794.88 up front, and then they bill either the private insurance and or Medicaid, and then they document that within their invoicing each month, and then that's less paid to them on that current invoice. And I feel like I'm missing something on your question, so if you could repeat the additional.
Thank you, I appreciate that. Can you tell me how many providers, how many early intervention providers do we have that this change would affect?
Thank you for the question, Ricky Robb, for the record. There are currently 5. And those some providers provide statewide. There's 2 providers that provide statewide, and then the others are one in Reno, the Washoe County area, and then the other 2 are in the Las Vegas region.
Thank you. And a transition in a state billing from a managed care to fee-for-service. Do you have any anticipated impacts that would have on the providers that are currently providing this service?
Ricky Robb for the record. Based on the information they have provided to us, they have stated that it will be an impact to them. However, this is the same model that we have moved to for all providers. As some of the individuals on this body will remember, we did this for the Autism Treatment Assistance Program. Very similar to that. We've also done it, I'm going to draw a blank on all the other programs that have done this. Really, Early Intervention Services, the last program that is currently in a pay and chase model, is what we typically call it. And so, again, they're really the last ones, but there's currently 5 providers that would impact. And they have provided that it would be an impact to them. I would let them speak to what that looks like as an individual business. But for us, we are looking at this as really ensuring our compliance with the federal on Medicaid as well as OSUP.
Thank you. Thank you for the opportunity to ask questions. If I may just make a statement, Madam Chair. Thank you so much. I appreciate the detail and that you've provided. And I just wanted to state that I have concerns relative to compliance. We've talked about that. We do know that we need to change the model that we have currently. My concern and hesitancy is with regard to the providers and the sustainability of the provider network that's providing this service for our children now. Having experienced how our state transitions billing, I'm very concerned that we haven't provided a runway for our provider network to be able to change how they're providing the billing for their services to work in cooperation with the state. I think that's going to be an important piece to the sustainability of the service that is so essential, these 0 to 3. We're talking about our youngest kiddos that have the highest level of need to help them be successful, which will then thereby decrease their reliance on all other health care. If we do this right, it's 0 to 3. And so for that reason, I will say that while I concur with part of the recommendation from our colleague, that providers need the time to create the transition model and the runway in partnership with the state, I would lean and recommend option E is where my head is at this point, so that we continue to pay this model and the state works in collaboration with the provider network to ensure sustainability. Thank you for this opportunity, Madam Chair.
Thank you. Senator Titus.
Thank you, Madam Acting Chair, I guess. I appreciate the opportunity to make a statement. It's really not a question to the agency. I think the one thing that we can all agree with, that ultimately what we decide, we're going to need a letter of intent. I think we can all agree with that. And so I'll start with what we have common ground on. And then I would just say that, frankly, I think the agency has been in this world, has done the homework. I think they are dedicated to making sure these children have the resources they need. I agree the 0 to 3 is the critical component here. But I also, this is a budget committee, and we have talked about possible federal impacts and decreasing funding and having to cut back. And I think it is they have done their job and being fiscally responsible, and I would support option A, which saves the state $10 million, versus option E, which costs the state over $21 million, which is a $30 million difference just doing the math. And so I just want to go down as giving the agency the credit for doing the homework, the stuff we have hammered them on this session, and I want to appreciate the work they've done. Thank you.
Thank you. Anyone else? Senator Nguyen.
See, she knows I have too many questions, and I may call some other people back up there. I just want to clarify on some of the documentation. I know this committee is looking at kind of a table that puts together the options that were described by LCB earlier. And I know in the governor's recommendation, there's obviously a savings there, and it shows a $13.8 million over the biennium. And for those in the committee that are actually paying attention, it's on page 8. And then, but also as a part of this, there's some additional funding that comes from some of those opioid funds as a part of those additional payments, and it's about 4.7. Am I reading that? So it's those two programs in there. I guess that's a question for our staff.
Kimber Ellsworth, for the record, Fiscal Analysis Division. Yes. With currently in the executive budget, the recommendation in the Early Intervention Services budget account is option A. So that would fund $13.8 million in provider payments, and in the budget account 3060 for the Fund for Resilient Nevada Decision Unit E225, that provides additional funding of $4.7 million over the biennium with opioid funds.
So that's about $18.5 million total between those two sources of funding to manage the program under the proposed new, I guess, mechanism.
Correct.
And then I guess this is a question for the agency. Regarding, obviously under the recommended proposal in the executive budget, and I'm not sure who would be best to answer this, With the addition of those bonus payments, bonus payment of using those opioid funds, what was the thinking behind that? Was that to fill up any gap? Because I know under the current, suggestion, there's still like a maximum billing cap of insurance proceeds up to that recommended burn study of 749 a month. So this seems like it would potentially put that well over an overfunding kind of this process if you were to give everyone a $200 per child bonus on top of that. Was there the understanding, and I think we heard some of this testimony, that there's like maybe an expectation that they wouldn't be able to bill to that whole full 700, and this would help supplant that or supplement that? Not supplant that, supplement that.
Dana Schmidt for the record. So in early intervention services, there are certain services that are required to be provided that are not billable. And so that 199 and the 88, if you look at the burn study together, that is the amount of what was anticipated in the study to be non-billable services. So those two combined together cover the non-billable services provided by early intervention providers.
And while I have you there, I guess my issue is over half of these kids, half of the 3,800 kids that are 0 to 3 years of age, the community providers that are providing these services, I just have concerns that now we are turning them into insurance expert billers. What kind of services and what kind of training have we done to help facilitate the issues with billing? Because I know that we heard some statistics about how you are only, let's see, in 2023, the revenue combined from Medicaid and private insurance was about between 3 and 12% of the total revenue collected by those community providers. But then we heard during testimony that there was some clarification that that's the amount that you're receiving, but there was clearly a disconnect in how people were billing, whether or not they were getting rejected for not knowing how to appropriately bill for all of these individual services. Having moved from a model where they just receive a monthly payment to one where they have to bill each and every one of these services. And given that some of these services are not billable, as you just indicated. So I'm wondering what kind of training, what kind of outreach has been done with these community providers to provide them the resources so we can try to start capturing that money more efficiently.
Ricky Robb for the record. With the Nevada Early Intervention data and system, that was the ultimate goal, was to support the community providers as well as the state providers in billing, because we obviously know that is a challenge, it's a lot of work, it's labor intensive. So the goal was to ensure that we had a comprehensive billing and data system. They also have the case management within that system. And then we have done training from day one. So we built the system. It went live December 1st of 2023. We did in person. We've done weekly. We are sometimes in those meetings 20 hours a week in training on the system as well as billing. We do have an expert biller, a subject matter expert. She's actually here today, Gina Callister. She has been working with them on an individual basis as well as group training. They submit reports or they submit concerns. We have a tracking system of all concerns that have come in. And so we work with the vendor as well to ensure that that is that if there's an issue within the system, that they're working on that to ensure that it's compliant and it's supportive. I will say we just got a report this week that the tickets that had gone in, the majority of them were data entry errors. So some of it's not just necessarily a billing area, it's just that it's learning the system and being able to get in. I will not claim that the system's perfect. It is not. However, that is the goal of that system, is for everyone to have the same processes, the same supports, and there has been ongoing training. We actually do kind of an open forum as well. They send in any questions. We look at the tickets that we've received, and then we do a meeting, and everybody is able to work on those together. Because if one group's having an issue, I would assume majority are having an issue.
It obviously, I guess my concerns is because that or that revenue coming back in from those like claims and those tickets are so low, and maybe this is the person that you just mentioned that is working with them. It seems like there's a bigger systemic problem, and does it lie with the community providers, or does it lie within the, maybe flawed system itself?
Ricky Rob, for the record, I would say it's a combination. I think we have a system that we've been working in for 14, 16 months. I don't know what the day is. And so, we have a new system. We have people that are billing. I think the challenge, though, on that is they've always been billers, right? That has been something that they have done, and I would say at one point they were probably better at it than many other programs, including the state. So I think that you get better as you learn and and credentialing and those types of things. But I think really all of us are working on it as well. I mean, the state's still a fairly new biller as well. And I would say we get better every month by what we learn and how we navigate that and the questions that we ask. So I would say it's a combination, but it's something that we must continue to work through. But really for us, we're really trying to be compliant. We were told by the subject matter expert from the feds is that they were surprised that we had not been hit on the payer of last resort. So we're trying to do our best. Timing wise, I understand seems tight, but we're trying to do our best to ensure we're in compliance while maintaining the services. I mean, the most important piece of this is the children, their families, and then obviously our providers and their businesses to support their own families. But I think that we're really doing our best to be compliant and to follow the rules.
Can I ask how compliant the state, it's roughly a 50-50 split. So how compliant are the state agencies in capturing this billing and the state providers?
Ricky Rob, for the record. We are at about a 65%, 65 to 80%. I need to get confirmation there. On billing and recruitment. So obviously we have growth as well. But I will say again, we're learning every day. We're asking those questions. We too have a data entry error issue. And so that is something that our supervisors and our staff every day have to go back in because it could be the difference of a transposed number or, a transposed letter in a child's name. That's going to kick it back. But if we aren't going back and checking those things and doing some quality assurance on our own work, we're never going to get there. So that's a big one for sure.
Do you know what your average per child per month billing that you're able to capture at our state providers? Ricky, for the record, we do not have that with us, but I'm happy to provide that. I know we've provided that in previous requests on both, but yes, we can provide that updated. I guess that just brings me to we've heard throughout session from the beginning when this budget dropped, it was obviously a huge shift for community providers that provide nearly 50% of these services. And they're having difficulty billing. But in addition to them having difficulty billing, it sounds like the state agencies that are providing, or the state providers are also having these same issues. So it seems like a lot to risk for a very vulnerable population to make that shift. And, I know as a committee, part of the reason we wanted to have this further discussion is because if the model as recommended by the governor, we've heard from the multiple community providers that they don't believe that they would be able to sustain their operations. And then all of those providers and all those kids would not be there. And the state would have to come in and take more than a 50-50 share. And I just don't know whether, I think we heard from you that you wouldn't be equipped to take on all 3,800 children that are currently on the program. But that kind of brings me to this. What kind of conversations, and I don't know who this is for, but I know in other areas around Medicaid in particular, and it sounds like about 2/3 of these kids are Medicaid eligible or on Medicaid, have we worked within the rules of CMS to figure out if we can come up with any kind of special payment methodology? I know that there's an ability to do that, capitation payment method through Medicaid where there's a monthly payment. And so, these community providers as well as state providers would have to have some of those quality metrics and fraud prevention metrics that I think we all think are important. Have we ever looked into that kind of model? Because I know it's difficult in a situation where some of the services are covered and some of them aren't. These community service providers, as well as the state providers, would have to individualize every single line item for any service that they provide these kids. So if the ease in providing quality services with a monthly payment kind of structure is possible, what kind of conversations have you had around that?
Dina Schmidt for the record. So we have been in conversation with Medicaid. We had a meeting with the Medicaid rate team and our providers to help understand, let our providers help explain what this service looks like, right? What this service model looks like, especially because these services are offered in the home. And so there has been some discussions regarding a capitated bundle payment. We have not estimated that cost at this point, but Medicaid has reached out to us and mentioned that that is an option that we could look at for this provider type. But we don't have an estimate of what that cost would look like today.
Thank you. And I don't know if it would be helpful if there's any figurehead for community providers that might be able to come up to the table.
If there's providers in the room that could come to the table to just give us some clarification of how changes, if any changes there were going to be, how the budget decisions we're looking at today will affect your services to our babies in this. Thank you.
Robert Burns for the record, Therapy Management Group, and I'm happy to answer any questions you have for me or provide any information that I can to help this body reach some conclusion. Thank you for the opportunity.
Hi, my name is Marnie Lance, and I am the Director of Therapy Management Group. I'm also a licensed early childhood special education teacher that's been working in this system for the last 20 years.
I guess my question is, you kind of heard some of my questioning about how the billing process works, how that works. How does that work for you all within, being the provider of services? Also, do you have whole divisions within your community provider, structure to handle this billing? What kind of conversations have you had transitioning to this new billing process?
Robert Burns for the record, owner of Therapy Management Group. I would say that our billing department has grown significantly in response to some of the challenges of trying to make sure that we're doing everything in our power to capture billable dollars. It's a moving target, and with the current structure, I would say that it's challenging at best, but I would also add that as a program, Therapy Management Group operates an outpatient clinic, and we have relationships and are credentialed with most of the insurance providers. And I would say that the reimbursement rates that we're expecting from this program, or that are projected from this program, just are woefully inadequate for us to continue to sustain an operational business.
I think that kind of brings me to the question. Is it the inability to bill that is causing the problems? I want to know why we're not billing. Like, where are the problems in billing? Obviously, the reimbursement rate might not be enough to be sustainable, but I'm curious on what are the challenges that you have in billing Medicaid? What are the challenges that you have in billing private insurance? Because if we can help solve those or figure out, understand where those problems are, I think that's one issue. And then obviously, if those rates are not sustainable to, like, justify operating in this space, that's a separate, completely separate issue. So I just want to make sure that we're in compliance, that we're billing when at all appropriate. And if it turns out you're billing at 100% and you're only getting back $500, that's a whole other conversation that we can have about how we supplement that to get you to a place where you're whole. But I'm curious on what are the exact problems that don't allow you to bill 100% of the time.
Marnie Lance for the record. It's multifaceted, but I'll go over a couple of the details. So one thing I would say with early intervention is that, we do ask for permission to bill, but unlike when you go to the doctor, you get authorization before you get services. That doesn't work like that with early intervention. Our federal mandates require that we start services in a specified time frame, and so to be federally compliant, we have to go ahead and get services started, regardless if we have prior authorization, and can then get billed and reimbursed for that. So there is a lag time there on actually getting paid for MCOs, private insurance, that sort of thing, where you might not get paid for those services because we had to do them within a specified time period. So there are some issues with that. The other thing is we do provide in-home services, so we have to travel there. The reimbursement rates that are out there are not based on a home-based model with transportation and lack of productivity. In a clinic-based model like we run for our other line of business, we have, you have kids coming to you, so you can see many more in a time period, which makes it work with provider rates. We have a provider shortage in the state of Nevada, so in order to get staff to provide these really needed services, we have to pay a rate to get them to stay with us. And I think the Burns and Associates study that was done increased our payments based a lot of the provider rates that are needed to retain staff in Nevada. And so that would be a major shortfall for us. And then going back to the non-funded services that ADSD discussed, there are a number of services that we provide that are not reimbursable, that are required federal mandates that we have to provide. We've had to do a lot more billing and a lot more admin time on billing than previous, which was not necessarily captured in the Burns and Associates study.
And I recognize that Burns and Associates study was actually based on, just came out, but was based on data, I think, that's now like 3, almost 4 years old. So I appreciate that. I just think that there are ways to bundle those payments, and this is maybe directed back to the agency. And I think my concerns in moving to such a drastic change, and this is not for any of you at the table, but I think my concerns in moving away from what we have currently and the way we have currently funded without having these conversations, potentially needing audit, potentially figuring out ways to bundle these payments so providers get monthly payments and waiving pre-authorization in these areas. I think these are all things that we can handle. I just don't know if we can handle it between now and July 1st of 2025. Thank you for your indulgence, Chair.
Thank you. And for the third gentleman who joined the table, if you'll go ahead and introduce yourself. And I know you came to the table because you have something to say, so go ahead.
Yes, my name is Mark James with Therapy Management Group, for the record. Just to add just a little bit of insight to Senator Wynn's question about do we bill, the answer to that is yes. Every child that we put into the system, that gets billed. Obviously, there are challenges from that. So this isn't a lack of effort for billing on our part. we bill for these kids. So the answer to that is yes. We may not get paid on all these kids, but we definitely bill. Thank you.
Thank you for helping as we go through all these options. Wanted to hear both sides and how this change would actually affect the providers who are providing the services for the kiddos that you dealt with. So I appreciate the insight. Members, any other clarifying questions for the agency or the providers, since we know we have them in the room? Assemblymember Brown May.
Thank you. I just have one clarifying question. I want to be really, really clear, and it's really for fiscal staff. And I'm going to go back to option E. I just want to be clear, option E is currently what we have right now in the state as our payer model. And so that would be a baseline prior to the governor looking at and making budget recommendations. Is that correct?
Kimber Ellsworth, Fiscal Analysis Division. Yes, that is correct.
Thank you, and forgive me, I have been ignoring the camera down south. There's someone at the table there. I'm going to give you an opportunity to introduce yourself and go ahead and state what it is you wanted to say to us.
I'm Dana Aronson, co-owner of TheraPlace Solutions, another one of the community providers. And I also wanted to second that we are billing for all of our children in our program. It's a lot of what we get back, or the payments that are proving to be difficult. Out of concern for our families and our company and the state of Nevada, it's not sustainable, and I think ultimately the state would be paying a lot more with some of these lower rates to the community providers.
Thank you so much. And again, forgive me for ignoring the camera. Well, all right, members, we've had a very good discussion this morning. And thank you, staff, for all of the many options that you provided to us. As going back to what Senator Titus was saying, no matter what option we go with, there will have to be followed with a letter of intent. But after the discussion, hearing from both the agency and the providers, I must say that I am leaning to an agreement with both Senator Nguyen and Assemblymember Brown May that option E would be where I would be leaning, along with a letter of intent, and in that letter of intent about the reporting, having reporting back to IFC of the progress of how we're moving. I believe there does need to a big change at this time in lowering the rates for these providers providing the services to the kids in our community. It may not be the best thing at this time. Maybe somewhere we need to get, but I just don't believe that's where we need to do right now. But that's would be how I'd be leading as the chair pro tem of this subcommittee today. So, Senator Nguyen.
Thank you. I agree with that. I would like to also see if there's anything that we can do to talk to the state agency about potentially moving forward, developing some of these other options and waivers within Medicaid to bundle services, to have some of these quality of care metrics, to make sure that that our state providers as well as our community providers have certain quality of care metrics that are tied to some of these payments, to make sure that we are doing this and really kind of dig down into some of these things where I think we have solutions to have bundled payments that ease for quality of care and ease of payment moving forward. So if that's something that this committee, I think, would be inclined to consider, I would ask for that consideration as well in that letter of intent, not only from our community providers to IFC, but also perhaps from the agencies on what they are doing to come up with some more creative billing solutions for our community providers.
Thank you for that. Members, any other comments or questions? This is a work session. There's not anything that we are voting on today. It's a conversation to help us get to a better position for this budget to actually be closed. And I believe that the conversation has given staff a lot of direction as to get us to where we need to be for budget closing. All right. I am not seeing any other questions or comments. I'll thank everyone that joined us today for sharing your comments and giving us a little more insight onto this budget. That's why we had a work session, because there were still a lot of outstanding questions. We want to do what's best for the state, for our babies most importantly, and for the providers that are providing those services to those babies. So thank you all. Members, that brings us to our last item on our agenda for today, and that is public comment. If you would like to call in for public comment, our number is 888-475-4499. The meeting ID is 85917196-596, and then please press pound. If you are here in Carson City and would like to make public comment, I invite you to the testimony table. If you're in Las Vegas, I invite you to the table there. Not seeing anyone approach the table here in Carson City and no one at the table in Las Vegas broadcast. Do we have anyone on the phone line that would like to make public comment at this time?
Chair, the public line is open and working, but we have no callers at this time.
Thank you so much. And with that, members, a lot of you I'll see in committees later today, but I'll see all of y'all in the morning. I know, joint fiscal on a Saturday morning. Okay. We are adjourned.
You know what? For all the committee members, I know that Senator John Darrow Loop is the chair tomorrow, and she is having the cafe cater breakfast for all of us. So there'll be some burritos and parfaits. See, she's not even paying attention down there.